we have Dr. Reena Chaudhuri, and it was a pleasure watching the previous presentation. There I am. So I'll be talking about iStent. We've already heard Dr. Sahiban talk about it. So some of it might be, okay. Is it working? Sorry, it's not working here. Can you just look at it? My cursor is not showing to cancel this.
We have a smaller screen, but the resolution of this is not
Finally
better.
it's
So it was
यहाँ पे
such
चल
a
रहा
beauty
है
seeing the surgery.
Wait, यहाँ पे बंद करते हैं. Now let's see. Is it working now? Sorry about this. Yeah. Yeah, finally, I think now it's working. So I'll be talking about iStent, and I think basically to just introduce that in primary open angle glaucomas, we basically treat our patients medically, and in some cases, we offer the laser basically in the form of SLT or ALT. And then straight away, the second options available or further options available are surgeries like trabeculectomy or tubes and shunts, which are offered in the slightly moderate to severe disease when you can't control the pressures or patients cannot use the topical medications. So we also know that medications, the challenges of compliance, cost, multiple drugs, quality of life. And if you look at basically the stepwise approach, the surgeries offered in traditional ways are basically trabeculectomy, the gold standard, and the trabs and tubes. But in mild to moderate disease, we are primarily limited to our drugs. But now, in the last few years, we have the MIGS platform showing up where we are looking at the possibility of offering some procedures to lower the intraocular pressure in mild to moderate cases of glaucoma. This is just to highlight the challenges sometimes with topical medication, and now the threshold is becoming much lower to offer a surgical option in patients where you have multiple drugs requirement. So MMT, which was first considered 4 drugs in maybe 3 bottles or 2 bottles, now it's pretty much in many surgeons' eyes is limited to about 3 drugs in 2 bottles. So we also know that these drugs have their own challenges, not just compliance, but the fluctuations of IOP is a problem, systemic side effects, local side effects in the eye, and of course, sometimes it's the cost and otherwise also the effect on the ocular surface that these patients do not comply very often to the required treatment. So this was an article by Dr. Sunita Dubey et al. At the Shroff Charity, Delhi, and they also documented that in Indian scenario, 50% of the patients do offer us full compliance, with the remaining 50 are either partially compliant or not compliant at all. We also know that the fluctuations do affect the visual field progression, as documented in this very popular study by Asrani et al. And of course, the ocular surface disorders with the drugs is something that we see every day in our clinic, and we know these patients are very much affected by the symptoms of the ocular surface rather than the problem of glaucoma. So that is also a problem that we should be attending to. So what we are talking about is that MIGS is here now, and it's here to stay. We already heard just now a presentation on cannulating the Schlemm's canal. There are other procedures that we are all doing, whether it is GAT or we are doing trabeculotomes we are using. We are doing the iStent. So in my talk, I'll limit myself to basically the iStent and iStent inject, which comes in between your first 2 stages, which is the medical management or trabeculoplasty, and before you offer a trabeculectomy. So basically, you're talking about mild to moderate disease. Dr. Sahiban already illustrated the indications for iStent. Basically, mild to moderate disease where you're looking at reduction of medications by a single drop or 2 drops, lowering the pressures by about 20 to 30%. And these are eyes which are not vulnerable, which do not have advanced disease. And of course, open angle is a mandatory requirement for this procedure to succeed. So angle closure eyes or any secondary glaucomas are contraindicated. This is how the iStent looks like, which has a head and a thorax and a flange, and it's a titanium made implant which is coated by heparin. And the injector is, it comes with 2 of these implants loaded onto the same trocar. So this is just to show you what it looks like. This is the trocar which is loaded with it, and you can inject 2 implants at the same sitting in every patient, about 2 clock hours away into the trabecular meshwork. So the head basically goes into the Schlemm's canal, the thorax is sitting in the trabecular meshwork, and the flange is what is seen in the anterior chamber. This is just a short video to show what it looks like. You already saw with Dr. Sahiban, the trocar actually punctures the trabecular meshwork. You indent it a little bit and you press onto the plunger and you click the implant to go and sit in that position. And you can also tap on it to make sure that it's sitting and it's not under implanted or over implanted. And I'll talk about it once I show you my detailed next video. And you ideally want to see these two implants about 2 clock hours away. And very often you will have reflux bleeding from these implants, which is very normal, and it settles down quickly. You can use any direct gonioscope in the operation theater. Swan Jacob works very well, but you also have this iPrism SX that the company is providing along with the iStent Inject, which works very well. So you can choose whatever works well in your hands. But the important thing is, before you move on to doing the iStents, one has to learn to visualize the angle on the table, and that's the first thing that you have to learn to do. Even in routine cases, you can try and understand how is it that you will learn to see the angles well. Basically, you have to tilt your microscope about more than 35 degrees, somewhere about 40 to 60 degrees towards yourself. Basically, the optics are moving away from you, and then you adjust your oculars to make sure that you're able to see the microscope in that angle, and tilt the patient's head in the opposite direction by the same degrees, so that then you are aligned to the angle and you want an on fast image of the angle. This is just a video to show you that I'm sitting here and now my assistant is moving the this thing to dial to try and tilt the microscope. You can see that it's already tilted a little bit. Can you see this paper mark on the microscope? That is about 50 to 60%. So I'm telling him to tilt some more. He keeps tilting till I know that I've achieved a tilt required to get an on-fast image. Once I have it, you can see the ocular has moved down from my eyes. And in this microscope, I can just tilt my oculars up. In case you can't do it in the microscope you have, you can always adjust your chair to achieve that. Then you turn the patient's head in the opposite direction. So you talk to the patient and say that I'm just tilting it. And now you have a good view of the angle the moment you'll put the gonio prism onto the eye. And now you can see that I'm putting a high molecular weight viscoelastic onto the cornea, and I'll take the gonioscope in my hand and just put it onto the nasal side of the cornea, and you'll be able to see the angle through the microscope. And I will, so that's the gonio prism, and you go and you put it there and you're able to see the angle immediately. So this procedure, I think we already saw that, but just to elaborate a little bit, you want to use sodium hyaluronate because it sits well onto the cornea and gives you a good interface between the lens and the cornea. And then you go, and this is the gonio prism that I'm talking about. You go and put it onto the peripheral cornea. It works very well. There's no indentation, and you can have a very good high resolution image of the angle. The moment you have it, you make sure that your tilt is adequate to get the on fast image, maybe just a minute or so. And you can minimize it to take your injector in. It is covered with a sleeve. The moment you cross the pupil and you're inside the eye, you can retract the sleeve with a plunger, and then you can go and touch the angle and implant your iStents. You can see the trocar is sitting within the tube, and there's a window on top of the tube so that you can see what is happening. Once you see the trabecular meshwork well, you go, let the trocar enter the trabecular meshwork, and just have a little indentation and press onto the plunger to launch the implant. And you can see a little bit of blood refluxing there. You go on and inject the second eye inject in the same manner, and then you can use a viscoelastic, which you'll just see, to wash away or disperse the blood and make sure that your stents are sitting well. In case you feel it's under-implanted, you can use the same injector and tap it a little and push it further down for it to sit ideally into the Schlemm's canal. See, now I've just used a viscoelastic and you can see well. So just to say that basically you are increasing the flow through the collector channels. And just, can I take 1 minute more, Dr. Meenakshi? Okay. So as you can see over here, this is basically an angiographic study of an eye before the eye stent, and then after you put the eye stent, you'll be able to see after, you'll see that in the areas where the eye stents are sitting, the amount of filtration happening is significantly more. You can also see it if you use Trypan Blue on the table, that after you inject these implants, the dye will start getting into your subconjunctival tissue. So basically, all these ab interno, all these MIGS procedures are basically ab interno so that you don't touch the conjunctiva. It's minimally invasive, and you're also leaving behind pretty much 85% of your trabecular meshwork untouched, actually 98% for any further intervention if required, and your conjunctiva is also untouched, and the chances of pus formation or endothelial cell loss in this MIGS is hardly reported. So, as I also mentioned, that it's a conjunctival sparing procedure, so a future possibility of trab or tubes is not hampered in these subset of patients. There's a lot of published data with iStent because it's been used now for many years globally, but in India now, in the last 1.5 2 years, we have patients who have been subjected to inject, and we'll have more and more data being published. This is a very large study by Hengerers, and you can see they were talking about 20 to 35% reduction in this subset of patients, whether you combine it with phaco or you do it alone, and also 71% medication reduction in these patients with lesser IOP fluctuation. So the ocular surface also improves in many of these patients because the requirement of the drugs goes down significantly. So just to summarize, iStent is a good option available to us for our patients requiring, let's say, a cataract surgery in mild to moderate glaucoma, primarily the open angle eyes, and it's basically bypassing your trabecular meshwork to have the fluid get into the collector channels through these iStent injects, and it does have very less risk and an added benefit. The cost still remains a huge challenge, but I think in the time to come, we are only going to see more and more implants, and maybe even the cost will become a little more viable, although the insurance companies now are helping us be able to inject these in our patients with glaucoma. And sometimes, very often, I think indications are patients who have open angle glaucoma, mild to moderate, with 1 or 2 drugs, and they need a cataract surgery. That's the time to offer this procedure to them. So thank you. If there's any question, I'm happy to take that.
What does it ideally cost the patient?
So, you're adding about 90,000 rupees extra to your cataract package when you offer an iStent. Even more, some people are even charging more depending upon how much. It is an expensive tool right now. Mr. Saikat is here. He can comment a little more on it. But yes, it is an expensive proposition. But insurances are giving it. And there are some of us, I think Dr. Amit has been using a lot and is able to get in Delhi NCR because of GIPSA. There is a little bit of a challenge. But I think more and more now, people are open to the idea that they will go up to the insurance companies to reimburse it later. Initially they pay up what extra they have to, so it's working, but I mean there is that roadblock with the cost.
And in the learning curve to master it, how long did it
I
take? Or
think
did you
if
have
you're
any fall?
Yeah, so of course, with any procedure, there can be a learning curve, but generally, technically, this is not a difficult procedure to do at all. It might look, because if you start doing it, I think it's a matter of just a couple
So
of
you never
procedures.
lost any.
No, I'll tell you
That's
what,
what
if it
I'm
drops,
asking.
it's very easy to rethread it. And especially if there is sodium
To find
hyaluronate.
it?
No, while you're doing it. See, as we also were discussing before the session started, if you lose it later, which you hardly will, then it's a different story. But if under visualization on the table, you've seen it dropping, you pick it up, you rethread it, you put it again. If you have put it in well, you tap it, you can actually go tap it. It's quite nicely fixated over there. And you're doing an IA. If it doesn't move out then, it's not going to move out thereafter. No. But yes, a learning curve, and all, sometimes also getting an on fast image. I think we don't realize sometimes that you want the trabecular meshwork really perpendicular. If the tilt is not adequate, and if you can see the angle but it's not on fast, then really getting into the Schlem's canal is a problem. You might be tangential to the trabecular meshwork, so the ideal placement might not happen. So anatomically, you have to just learn to get the nicest image, and the angulation go up to almost 50 to 60 degrees. Don't stop at 35. I think that's the key, to have a higher tilt, so that it's a little difficult if you don't have your eyepiece. You can't lift it, then you have to kind of bend down, move back to be able to, and your hand length will increase to access. Now you'll be sitting a little further away, but these are small modifications you will quickly adapt to. And if the moment the trabecular meshwork is perpendicular and you want to inject perpendicular to it, it'll launch into the Schlem's canal.
The
Anytime
cost.
does it
Yes,
does
yes.
it get blocked with blood, or the
Because it's
viscoelastic,
heparin coated, usually that's not an issue. It's not an issue. Yeah.
So the
Not that
cost
I've seen.
cost is for the Gen 1 is 69,000 is the MRP, and for the Gen 2 is I think close to 1.5, and that's the MRP, and I think the hospital rate would be lesser, much lesser. And I've done iStents. I've done almost 17 now, including iStent Gen 1 and Gen 2, and almost 13 or 14 of my patients have been either fully or partially covered under insurance. So that's something. Yet there is no capping on these implants. So
Thank you.
we can take that
Yeah.
advantage.
You have a question.
Thank you very much for that insightful presentation. My question is, do you have preferences for the quadrants that you start with?
Yeah, so basically, if you're making a temporal incision, that's what you're used to. You're implanting it in the nasal side because you have to implant it in the opposite direction. But if you're familiar with the superior incisions and all, sure, you can do it. But I primarily do it in the nasal side, which means you're accessing it from the temporal side.
Okay, why I
So
ask
the-
that question is based on the anatomy of the angle with regards to the collector channels, where
Correct.
we have
So
a
the
lot of
nasal
them.
and the infero-nasal area is the largest
Best.
amount of collector channels that you have. So it's best to always do it, even if you have done a superior phaco, you have a temporal side port. So you change your position, go through the temporal side port and inject nasally. Nasal and infero-nasal is the ideal area that you need to inject it.
Yes,
Yeah.
okay, thank you very much.
Doctor, would you introduce yourself? You've been asking very great questions.
My name is Professor Adeola Onokoya. I'm from Lagos University Hospital, Nigeria.
Welcome
Thank
to
you.
India. Thank you.
Thank